Hi, my name is Harvey Shi, and I'm an MD PhD candidate at Duke University. I'm presenting on behalf of my team at the Duke Institute for Health Innovation and the Duke Heart Center. Our presentation is on predicting cardiac decompensation and cardiogenic shock for patients at Duke Hospital. Cardiogenic shock is a condition where the heart cannot adequately pump enough blood to the body, typically caused by a heart attack. As you can imagine, it is a condition associated with very high morbidity and mortality. The in-hospital mortality rate is 27 to 51%. In earlier work, we examined the cardiogenic shock mortality rates at Duke Hospital and found them to be 21 to 30%. As such, it can be very important to identify the early predictors of cardiogenic shock. However, while our goal is to be proactive about the early intervention and prevention of cardiogenic shock, it can be difficult to define. As such, we decided to develop digital phenotypes for a more general condition, known as cardiac decompensation, which, if untreated, can lead to shock. We modeled 6 digital phenotypes that represent different facets of decompensation in cardiac patients. These phenotypes can be used to assess ground truth deterioration outcomes, such as ICU transfer and mortality. So here are the phenotype definitions we developed, which are based on vitals and analyzed data from the EHR. They are a mix of the pathways leading towards further decompensation, such as hypotension and respiratory decline, as well as the interventions for these conditions, the vasopressor administration and the respiratory intervention. There's also a fever phenotype, which can be used to give more clinical context about the source of decompensation. Our modeling dataset was constructed using 347 data elements from 100,000 encounters and 70,000 patients at Duke Hospital. We included basic patient demographics, analytes, vitals, vasopressor administration, and comorbidities grouped as CCS classes. This data includes a mix of hourly time-aware data, such as analytes and vitals, as well as time-unaware data, such as age and comorbidities. The models were trained using data from October 2015 to August 2018. We used LightGBM, a gradient boosted model framework, to develop these models. On the right, we see the model performance and hourly prevalence. For each phenotype, there are 2 models, the 12 and 24-hour versions, which assess whether or not we meet each definition within the next 12 or 24 hours. We also have 2 combined phenotypes, which allow us to capture patients who have either had a deterioration event or were intervened on. These phenotypes and models come together in our cardiac decompensation dashboard, which is built in Tableau. If a phenotype is met, the dashboard will show the timestamp in red. Otherwise, the risk score for meeting the outcome within 24 hours is shown in blue. Our goal is to deploy this dashboard soon in early pilot workflows for cardiology units at Duke. Thank you so much for watching our presentation.